4, 3, 2, 1. Sir, we are live now.
Okay. So I'll start sharing my screen.
So we'll just
yeah, please allow me to.
yes, just Dr. Godhasiri, if you would like to introduce Dr. Ashish Ranade, sir. Dr. Godhasiri, I think you're muted. We can't hear you.
Okay, I think I'll start sharing my screen.
So good morning, everyone. Today we have a lecture by Dr. Ashish Ranade, sir, on congenital vertical talus. So I would like to thank sir for taking out his precious time for teaching us fellows the management of this deformity.
Good morning, everyone. Thank you, Molin bhai. Thank you, Meet. Thank you, Godhasiri. It's been a pleasure, and I'll be sharing my views on congenital vertical talus. Thanks for taking out your time on Saturday morning. Thanks, Shyam. So as you know, it is a relatively rare disorder. We do not see many of congenital vertical talus. It's not definitely as common as congenital club foot. Pathology-wise, it's the dorsolateral dislocation of the navicular on the talus, and it is associated with number of deformities. We'll see more about that. There is associated equinus of the hindfoot, associated valgus. Then there is midfoot dorsiflexion and forefoot abduction. And all this is because of this dorsolateral dislocation of the navicular and talus. So almost 50% of cases, they are isolated. But having said that, 50%, they have some associated neuromuscular anomaly or spinal dysraphism or arthrogryposis or some syndrome association with it. The commonest things, if you are seeing a child with congenital vertical talus, are look for signs suggestive of distal arthrogryposis, myelomeningocele, spinal dysraphism, trisomy 13, 15, and 18. Interestingly, I treated this child. On one side, this child had club foot, and on the other side, there was congenital vertical talus. So, I mean, I could not find anything. He had MRI of the spine, brain, was seen by neurologists, but nothing was found. So sometimes it is possible, but have very high index of suspicion and make sure that you are identifying the neuromuscular cause while treating a child with congenital vertical talus. As you know, the differential diagnosis, the differential diagnosis comes into picture at early stages in infancy or neonate, and they are severe calcaneovalgus foot, then severe flexible flat foot, and oblique talus. So what sort of differentiates congenital vertical talus from all these differential diagnoses is that the dorsolateral dislocation of the navicular, which is irreducible, and the hind foot, which remains in equinus. So clinically, you will notice that there is medial bump, which is the flexed talus, and that is pointing towards the plantar surface on the medial side. That will be seen in these conditions as well as vertical talus. But if you do plantar flexion, that bump goes in because the talar head is getting covered with the navicular. And also, if you do dorsiflexion, then the equinus of the hindfoot or the equinus at the ankle joint is getting corrected, which does not happen in vertical talus. So the diagnosis can be difficult in neonate. but X-rays are useful. We'll see more about evaluation of this. Again, to have a recap of the pathoanatomy, it is hindfoot valgus and equinus. There is associated contracture of the tendo Achilles, posterolateral capsule of the ankle, as well as subtalar joint. Then there is midfoot and forefoot abduction and dorsiflexion. It is associated with tibialis anterior contracture, contractures of the extensors, peroneus tertius, and the hallmark is the dorsolateral dislocation of the navicular on talus. In severe cases, it can be associated with dislocation of the cuboid over calcaneus. That sort of continuation of the spectrum of the severe form of congenital vertical talus. So based on that, there is a classification, Coleman classification. It divides congenital vertical talus into two types, type 1 and type 2. Type 1 is where there is only dorsolateral dislocation of the navicular, but in type 2, it is associated with, in addition to navicular dislocation, the calcaneocuboid joint is also dislocated. But these classifications are not commonly used, and they do not help us in deciding the treatment. So the classification is only for academic purposes. A clinical evaluation mandates a comprehensive physical exam, always possibility of associated neuromuscular cause or any dysmorphic features suggestive of syndrome, or distal arthrograposis, any facial features should be looked for. If required, genetics and neurology consult should be obtained. Also, it is important to obtain MRI of the spine and brain if one is suspecting neuromuscular cause. Then foot examination is very important. That will tell us how flexible or rigid the deformity is. And again, once I stress the importance of the dorsolateral dislocation being reducible or not, and the correctability of the hindfoot equinus. So X-rays, standard X-rays which are done are weight-bearing AP lateral and stress plantar flexion lateral and stress dorsiflexion lateral. So here you can see that in this weight-bearing X-ray, the talus is completely plantar flexed. Then there is a break at this joint, and the hindfoot is in equinus. And this talar head, which is seen on this side medially. So even though it looks like there is no equinus, this break is happening at the midfoot joint, which is distal to the talar head, and that's why the name rocker bottom foot, like this convex base planovalgus. So even though it looks like there is dorsiflexion, this dorsiflexion is happening over here, and the ankle joint is in equinus. So that's the hallmark feature of this condition. So certain angles which are measured, and as you know, at early stages, the bones may not be visible. The navicular and the cuneiforms, they do not appear till 3 months of age. So practically, the angle between the long axis of the talus and the first metatarsal, they should line up or they should be parallel to each other. That's called Meary's angle. So those angles are measured, and the angle between the base of the first metatarsal and the talar axis, that is called TAMBA, talar axis first metatarsal base angle, that would differentiate between the oblique talus and the vertical talus. So especially in slightly older children, this angle is very useful. And this Meary's angle, the angle between the first metatarsal and the talar axis, should be measured in neutral lateral view. So this talocalcaneal angle, the tibiocalcaneal angle, as you can see over here, it will tell us whether there is equinus at the ankle or not. The talocalcaneal angle in lateral as well as AP view will help us to differentiate. That's the another view, just showing that the angle between the long axis of the talus and first metatarsal, that is increased, showing the congenital vertical talus in this shape. So treatment in younger age group or in infants or neonate, it's the reverse Ponseti method. The other option is single stage open surgical release, but that's typically reserved for older children. And then there are salvage procedures for late presenters like Kreisgren extraarticular arthrodesis, navicular excision with open reduction, and lastly triple arthrodesis. So as you all know, reverse Ponseti is serial manipulation and casting, and with subsequent casts, the foot is stretched into plantar flexion and inversion. One is trying to reduce the dorsally dislocated navicular, and at the same time we are trying to reduce the plantar flexion of the talus, but that may not be possible, and it may look like we are recreating cavovarus foot, or with every cast we are trying to increase the varus and plantar flexion. So those are the pictures showing manipulation. With one hand, pressure is being applied over the plantar flexed talar head, and with the other hand, the forefoot, which is dorsally dislocated, uh, we are trying to bring it down and adduct and correct the abduction. And once we correct the forefoot deformity, we do percutaneous T8 anatomy. We, if required, we do dorsal capsulotomy of the talonavicular joint, and the talonavicular joint is fixed with a K-wire. Percutaneous K-wire can be difficult, especially in infants, and many times I find it extremely difficult to percutaneously fix the navicular to the talus, and in many times it is necessary to make a small incision, visually see the joint, reduce it, and then hold with a pin. So that's the picture. That pin is being left there for about 6 to 8 weeks, then it is removed, and it is also important to do assist the TA tenotomy. One stage open reduction, there are various ways of doing it. Some people do it through single approach, some people do it through two approaches. So essentially it's um, releasing the contractures and reducing the joint. So peroneal lengthening is necessary, extension digitorum brevis needs to be lengthened, capsulotomy of the calcaneocuboid, then TA lengthening with ankle capsulotomy, and associated medial release is also. Intraoperative picture showing irreducible dislocation of the talus, of the navicular over the talus. So this child is older child, 3-year-old. I used two incision approach, a medial approach and a lateral approach, and in addition I also did posterior TLA, percutaneous TA lengthening, and then this was reduced, and I pass a K wire from the talar head and bring it out on the posterolateral side, and then back it up again. And I use that as a joystick to correct the plantar flexed talus, and once that is reduced, manually I reduce the navicular over the talus and push it forward. And that's how the reduction is maintained. I tend to keep these wires underneath the skin and put the child in a cast. And that's how this was treated. It's showing the reduction of the dislocated joint. Sometimes you may get this condition because of abnormal or imbalance of the muscle process. So this 10-year-old had a spinal cord tumor and was treated, and he developed these deformities because of uh, muscle imbalance. So in this child, we corrected this with Greisgren procedure and maintained the reduction. Recently, people have started using this reverse Ponseti in untreated CVT in walking age children also. Maybe that is something like Ponseti being tried in all age groups way forward, but I have not tried this in older children. But definitely next time I see an older child, I'm going to give it a try with few casts. So very recent paper published recently, and there is another paper which is looking at relapsed CVT, which was treated with sort of similar procedure. So again, they started casting and they treated with open reduction of the talonaviculation. So these are sort of recent advances, something to look forward to. And yeah, we'll definitely like to try. So that's all from me. Thank you.
Thank you, sir. So now if there are any questions, please put them up on the chat and we would ask them to sir accordingly. So I'll start with the case presentation. Okay, so this case is a management of idiopathic type of a CVT. So we have a 1-month-old who presented to us with this kind of a picture. As sir has said that as we can see, the hind foot is in equinus and valgus, and there's a midfoot break which we can see, and the forefoot is abducted. So as sir has, so how would we like to proceed in this kind of a picture? As sir has already mentioned that we in this age group, in the younger age group, we commonly use a reverse Ponseti technique, and that is how this was a paper published in the JBJS, a landmark paper published in JBJS 2006 by Matthew Dobbs. So what they did for this was, there were 11 patients, were total 19 feet, and they had a minimum follow-up of 2 years. So first they performed serial corrective casting, as sir has mentioned that we try to recreate the club foot deformity, and this was followed by a limited surgical procedure. The surgical procedure that they did was percutaneous tenotomy, or which was required in all cases, or a percutaneous talonavicular fixation, which was done in 12 of the 19 cases, or fractional ending of the tibialis anterior or peroneus brevis, depending on the remaining deformity after the correction with the wire. So this was first, initially what we did was we started with the reverse Ponseti casting. Weekly above knee casts were given, and all components in this are corrected except the equinus. So the foot is gradually stretched into plantar flexion. As we can see, the left foot of the child is being corrected. So the left thumb of during the malleation, the left thumb is kept at the head of the talus, and we gradually pull it into plantar flexion and inversion. Careful molding of the arches, malleoli, and head of talus, and above the calcaneus. These are the 4 areas where molding needs to be done. And this is gradually done till the lateral view of the foot in the last cast is around the tamba angle that sir has mentioned, talar axis and the first metatarsal base angle is less than 30 degrees, because this is suggestive of a reduced talonavicular joint. So this was after getting maximum plantar flexion. So if the tamba is less than 30 degrees, this means that the joint is well reduced. And as per the paper Matthew Dobbs, they suggest a retrograde talonavicular pinning. And if the tamba angle is more than 30 degrees, then the joint is said to be not well reduced after 6 casts. And in such cases, they suggested uh, that we should try to percutaneously lever the talus into position, and then after, if that is successful, then we again do a talonavicular pinning. However, if that could not be done, then we need to, as sir has mentioned, the two incisions. We do one medial incision over the talonavicular joint. We do a capsulectomy of the joint and then reduce it into place. So this is similar to what we performed. We performed the reverse Ponseti casting followed by talonavicular pinning. And this is what we had at 1 year follow-up. So as we can see, the hind foot is no longer in valgus. Uh, the midfoot break that was visible in the previous picture is corrected well now, and the equinus has also been corrected well. So this is what we started with, and this is how we corrected the deformity. Thank you. Would you how would you like to comment on this case, sir? If there's anything that could have been done differently.
Yeah, so very, very nicely done case. I mean, few questions to you and to other participants also. In a young child, how do you reduce that, or how do you sort of pass that wire? Any tips or any practical points?
So in a young child, there's no ossification visible yet. So I think we'll have to palpate and accordingly try to pass the wire between the first and second metatarsals. How do we do this?
Yeah, so Shyam or Dr. Agarwal, any comments or any tips?
So I have never been able to reduce the talonavicular joint using the reverse Ponseti technique. So I use that particular casting primarily to stretch the extensor tendons, the mechanism, stretch them all out. So your tib ant, your extensor hallucis, your EDC, your EDB, all of those things, I use it to stretch. So they all end up with a small incision opening the talonavicular capsule dorsally and medially, but not extending plantarwards. And I often will use a small freer to help lever the talus back up. And then pass, like you said, Ashish, I pass the pin antegrade through the head of the talus into the body and out the back, and then, or rather retrograde, and then antegrade it into the navicular under vision. That's what I do. Dr. Agarwal, what do you do?
Sir, I have poor experience with reverse Ponseti. That's why I put the question in the chat. I always end up with operating them later on and putting a wire open, reducing them at a later stage in life at around 1.5 years or 2 years. So I do try Ponseti method, but I am never successful with this reverse Ponseti.
Yeah. So one of the things that I have, and this is completely anecdotal. One of the things that on the lateral in a 2 incision technique, when you're doing Ashish, one of the things you could do is a peroneus brevis to peroneus longus transfer, so that the eversion force of the brevis is taken away and converted into more of a plantar flexion force like the longus of the first metatarsal.
Okay.
In my mind, I think about it and it seems like it should help. I do it fairly regularly in flat foot surgery these days.
Okay. We'll definitely try. So, Shyam, I read that you mentioned you use ultrasound to diagnose these in. Can you tell us a little bit more about that?
So See, the talus is often ossified when they are born, but the navicular you cannot see. And if you have a good ultrasound tech and you do the ultrasound along the medial arch, medial side of the foot, the midfoot, you'll be surprised how beautifully you can see the anatomy, the talar head and the navicular dorsally displaced. You can see it very, very nicely. So in the little children, when it looks like you're not sure if it's an oblique talus or a vertical talus, I usually get the ultrasound and have the ultrasound tech plantar flex the forefoot, and you see if the navicular reduces on the head of the talus. If it does, then it's oblique. If it doesn't, it's vertical talus.
Okay, that's interesting. That's nice to know. So you still do X-rays or you completely
I
rely on?
do X-rays still, yes. I still do the plantar flexion. So when I see the children, I just like you said, an AP, lateral, in dorsiflexion, and I don't they rely on dorsiflexion as much. The
Mhm.
plantar flexion lateral is the more important view for this.
Yeah. Okay. Thank you.
So, sir, we have a couple of questions in the chat. So, sir, one question from my side, sir. Are there any foot characteristics that point towards a neurological nature of the CVT?
No, not really. It's very difficult to differentiate just looking at the foot because it can be just isolated manifestation of something neurological.
And sir, another question by Dr. Gaurav Gupta. How do we differentiate a CVT with a severe planovalgoid and calcaneovalgus feet?
It's the reducibility of the navicular over the talus and the equinus, correctability of equinus. So in calcaneovalgus, in weight-bearing X-rays, you will notice that there is no equinus at the tibiocalcaneal joint, which will be there in congenital vertical talus. And I think that also differentiates the oblique talus from the vertical talus. In oblique talus, it's even though it's a sort of the talus is plantar flexed and there is midfoot break, but there is no equinus at the hindfoot, which is present in CVT.
And sir, another Anil sir has mentioned that CVT treated by reverse Ponseti gradually collapses into flat foot. So, what are the views of everyone else on this? Also, what are the types of braces used post correction, and what would be the duration that you would normally keep it for?
Yeah, so far experience with reverse Ponseti is good. I have not noticed that them collapsing into uh, medial collapse or flat feet. I usually put them in AFO and prevent the abduction at the forefoot. I use it for 6 months. But it would be interesting to know what everyone else is using. There is no standard protocol as such.
Okay.
So I actually modify the Dennis Brown bar. The Dennis Brown bars, when you use for clubfoot, they have a built-in eversion in them, right? So the foot is everted in the Dennis Brown bar because of the bend in the bar.
Yeah.
So I disengage the two pieces and I flip it the other way. The vertical talus side, I flip it so that it inverts that foot.
Okay.
And the Mitchell shoe, I put that in internal rotation, not outwards like we do for the club foot. So in the club foot, you set it out with unilateral at 60 degrees or so, and then bilateral at 50 or so. In
Mhm.
this, I put it inwards at about 40 degrees or 30 degrees. So you're basically in the young child who is non-ambulatory, you are doing a dynamic thing with the Dennis Brown bar and the Mitchell shoes, except on the CVT side, the foot is kept inverted and internally rotated. And when they get to walking age, I switch them to AFOs. But I use this exactly the same way as we do for club feet. Again, very anecdotal, very, very few patients. This is very rare. I mean, again, for every vertical talus I have treated in my life, I've probably treated maybe 20 or 30 club feet or even more,
So what is the casting protocol that is followed with this kind of a splint? Is it similar to clubfoot?
Yeah, casting is just like the reverse Ponseti. So I
I mean,
do
sorry,
it.
the bracing protocol. Sorry.
Oh, bracing. Yeah. Bracing I use just like club feet. So let's say I see a newborn with a vertical talus deformity. I start casting them right away. And I will get an ultrasound and see if the navicular is reduced on the talus or not. And if I can get the foot fully plantar flexed and inverted, almost as though they are ballet dancers, so the foot's almost pointing down, but if the navicular is still dislocated on the ultrasound, then I bring them to the operating room and I will plan on an open talonavicular reduction and pinning and percutaneous heel cord tenotomy and cast application. That stays in there just like in clubfoot. I leave it on for 6 weeks. I leave it longer because I feel that the scarring around the talonavicular joint keeps the navicular from redislocating up. When they come out of the cast, I put them into the Mitchell shoes and the bar, but I switch the bar the way I told you and leave it full time, 23 out of 24 hours a day till the child pulls up to stand. So 9, 10 months of age, I transition them out of the full-time use into nighttime use and a daytime AFO for weight-bearing use. And I continue that till they're 4 or 5 years of age. So I still brace with the Mitchell shoes and the bar longer than what more recent reports say. When Ponseti first talked about this, he used to use the bar till the kids pulled up to stand. That is what I still do.
Dr. Menon, good morning. What do you use for bracing? What's your protocol?
We can't hear you, so I think you're muted. I don't think we can hear you, sir. So so shall we?
Yeah, please go on to the next question.
Yeah, so we start with the next presentation by Dr. Godhasiri. Dr. Godhasiri, kindly share your screen.
Okay, sir. So I'm going to present a case of a congenital vertical talus in a 1-year-old child. So we had a 1-year-old boy and he presented to us with this deformity, a classical rocker bottom foot with convex plantar surface, and the foot is everted into valgus and externally rotated. So these are the clinical pictures, classical rocker bottom. And here the radiograph, we can see the talus is in vertical position, the calcaneum is in equinus, there is increased talocalcaneal angle. And if we look at that green line, which is passing through the long axis of the talus, it is passing below and behind the cuboid, which is actually supposed to pass through the lower part of the cuboid. And then the long axis of the calcaneum is passing plantar to the cuboid. So with this in a 1-year-old child, how will we manage so?
So, yeah, go ahead.
So So these are few studies which I've gone through literature. So the first one here, the dorsal approach as well as the posterior approach were compared. So 24 patients with 33 feet were operated, and 25 feet posterior release was done, and an 8-foot dorsal approach was done. And here in this study, they found that the dorsal approach had better clinical outcomes, the operative time was less, and there were fewer complications. Similarly, in another study by Raghav Saini et al., 20 feet were operated with a dorsal approach. They have a 4-year follow-up of these children, and they found that the dorsal approach had lesser revision surgeries and less complications, including less occurrence of osteonecrosis of the talus. So this case we managed with a dorsal approach. The tibialis posterior was dissected, and the talonavicular capsulotomy was done, calcaneocuboid capsulotomy, ligament releases. Then the talonavicular joint was aligned and the retrograde KY was passed. Here we can see that the talus and the metatarsal base angle is restored. So this is pre-op, and this is the post-op X-ray showing good correction, and the angles are all restored. And here we can see this was the initial presentation, and this is 2-year follow-up showing good correction, and the child is doing pretty well. Thank you, sir.
Thank you, Dr. Godhasiri. Am I audible?
Yes. Yes.
Yes. So, thank you, Dr. Godhasiri. Sir, for dorsal approach, sir, how has your experience been with this for the single incident?
So very nicely done case and excellent result. I somehow tend to use 2 approaches. I tend to use the lateral approach and the medial approach rather than one single approach. So I have no personal experience with this.
Sir, intra-op, sir, how do we decide whether we need to perform a T-band lengthening or a peroneus brevis transfer? Intra-op, what do we look for?
So reducibility of the talonavicular joint will decide that. But as I have not used it, I have not tried casting for these kids, but reading at those recent papers, I think it is worth giving it a shot. Put them in cast, and like Ponseti, it might stretch out or it might lead to as they have shown. But yeah, that is something I would definitely try next time I see older child.
So we have a question by Dr. Vidyasagar, sir. Do you have any experience with reefing of the spring ligaments?
No, I'm not doing reefing of that. Vidyasagar, are you using that?
Yeah, yeah. I do that sometimes because once the talus comes back in position, there is this inferior thing which is quite attenuated and long. So I rebreast it or cut it down and then suture it again so as to bring it very close. I have to see how it works, but it definitely improves the arch to a greater extent than just the bony corrections.
Okay, and you do that through the medial approach or?
Exactly, I follow your thing. I do a medial and lateral approach, and I have never tried a dorsal approach, and probably because I was not exposed to that. And the other thing is Dr. Shyam has mentioned about transferring the peroneus brevis to the longus. I have found it easier to do when the children are more than 1 year. I do it all the time, but in a child, a very small child where you have done a reverse Ponseti and you're trying to do a percutaneous stenotomy, sometimes the peroneus are quite tight. I don't know whether that could be called a neurological foot, like Dr. Moulin had asked. But in those cases, I try to release it, but the tendon is very, very thin and flimsy to do any repair. So I just let them slide in their own position and correct the foot. That's what I do. They are very flimsy.
Agree.
Okay, sir. So I don't think we have any further questions.
I have one more question I would like to ask everyone. Recently, my experience has been when we catch this vertical talus very young, and when they present to you in about a week's time, you do ponseti, reverse ponseti, and then by around 4 to 6 weeks, they are ready for your next talnavicular pinning and tenotomy. However, the child, like everybody's experience here, I have been also unsuccessful in doing it percutaneously. In few cases, I've done it successfully, but most of the times we have to open it. And then when we open, it comes to a general anesthesia. And usually even the anesthetists and the parents are reluctant to a child who's less than 3 months. So what do you do? Do you just keep on postponing the things by putting cast, or you delay the treatment? Please share experiences.
Yeah, I agree with you. That's a very valid point. I also have apprehension, or parental apprehension is there, operating on a young child. So I tend to continue with the cast little longer till the child passes that 3-month mark. Yeah, Shyam, what do you do?
Yeah, so here it's a little, the 3 months is okay. We sometimes face resistance till